Hey everybody, this is Kevin with NursingKAMP.com, and this is my Fishbone course covering Bicarb, CO2, an often overlooked lab value, but it is part of the BMP, and it's very important because what's going on, the underlying cause. All right, welcome to the Fishbone Lab course where we're looking through the BMP, where we're covering all the electrolytes found in this Nursing Camp book with membership on nursingkamp.com or social media. All right, CO2, bicarb, HCO3. A lot of times they use synonymous within one another. So that will kind of give you an idea of memorization of these lab values. Now, in an ABG, you have your bicarb, which is your HCO3, and that range is generally 22 to 26. And I used to say in some of my study sheets have 22 to 28, and these lab values tend to be all over the place. When you see a CO2 level, it's just like with chloride. Chloride's going to be a little bit vague, and so sometimes when I'm doing this and I'm looking at numbers, sometimes I'll change them to fit more current standards and stuff like that, and then they just haven't been switched over. All right, so CO2. So I generally will take this 2, put that 2 there. There's 2 of them, so 22, 2. So 2 plus 2 plus 2 equals 6. So 22 to 26, and that will give you your CO2 range. Like I said before, the ranges are for CO2 are kind of vague. NCLEX will never ever test you on a CO2 level. It just doesn't make sense. A lot of times we use them in practice. So if we're looking at CO2 level, we're going to look for the underlying cause. So take those numbers with a grain of salt. Not necessarily gold standard, so they tend to fluctuate. 22 generally is, however, the top number 28, I've seen 27, 29, and so on and so forth. And I'm currently doing 26 because in my class I do ABGs and we focus more on just 22 and 26 because of a lot of the lab values are based on those numbers. All right, so let's get into high and low. And when we're looking at high and low, previously we talked about chloride, and chloride being up there. And we said that, we talked about Addison's disease, we talked about Cushing's disease, and they show up again because it's the same thing. It's about the adrenal glands and the acid-base balances. So when you're looking at CO2, you're looking at acid-base balances. So it's the acidic part of the waste products of the blood. And when you're looking at the aerobic, anaerobic metabolism and how the body is using oxygen, what happens is you get a byproduct. And this acid-base balances works heavily with sodium and potassium. So these all work together when we're looking at it. So you're going to see a lot of variances with that. So what do we do for this? So now, will NCLEX ever test us on it? No. NCLEX will never test you on a CO2 level. It just wouldn't happen. They're most likely to test you on HCO3, which is part of a blood gas, not a venous draw. Because remember, a BMP is venous, right? And a HCO3, a ABG is arterial. So two different mechanisms as far as taking a sample from it. So let's look at the symptoms and what we're looking at here. So you can see right here, you have acute renal failure with low. You have diarrhea, dehydration, Addison shows up again, and you see Kussmaul. So generally what happens is that generally how I teach this in class, when I look at this in practice, is that if I see the CO2 low or high, I look somewhere else. And then I start to look at, are they diabetic? So what was the last blood sugar? Are they being managed? Are they a COPD patient? Are they emphysema? As you can see with high, do they have NG tube? And if you think about it, NG tube is taking out all the chloride, and it's now what will happen is that we're going to see this balance, right? So when you're looking at like with NG tubes, a lot of times what happens is they become acidotic, and then you see these balances and there's shiftings going back and forth between chloride and CO2. So generally, if the chloride is high, the CO2 is low, and if the CO2 is high, then the chloride will be low. So there's that tandem inverse relationship. And generally what I'll look at, are they a respiratory patient? Are they emphysema? Cushing's or Addison's, I would just expect it to be abnormal, and you can see high is with that. Potassium low, once again, working with CO2 and chloride and sodium. There are some meds that kind of relate to it, though it's all nuts to know, so I would never recommend memorizing these things and stuff like that. But if you think about it, cortisone shows up again, cortisol, steroids, and then you see aspirin again, and you see diuretics again. So these common things start to keep on showing up. And, when you think about acidic aspirin and all these types of things, they're going to affect this acid-base balance. So looking at these two labs, always think about acid-base balance and what's going on. How does the body compensate for this? Well, respiratory, right? And so ventilation is one. So breathing starts to increase, decrease, and so on and so forth. And so you'll see respiratory, but if the patient is diabetic or they have renal problems or something like that, this CO2 will be affected. It's the same thing with chloride. So always remember that. So whenever you're looking at chloride and CO2, whether they're high or low, look somewhere else. Always think about Addison's, Cushing's, and steroids. Those tend to be the main factors that we tend to see out there. And Cushing's disease, However, you don't see, cystic fibrosis with this. Can it be affected? Of course it can, because if chloride's affected with a low chloride, then the CO2 will generally be high with cystic fibrosis. So I don't memorize both of them, right? So I get chloride down, and once I know chloride, I can know that the opposite will be for CO2. And so that's what it's about. It's about application of understanding, not going nuts to know on memorization of all these types of things. So that's kind of why I have this in the book. The book is kind of good to just kind of jog the memory and get things going. But really what happens is that if you know those basic concepts, Addison's, Cushing's, cortisol, adrenal glands, diabetic, pulmonary, and then you can kind of figure out where that patient will be. So always remember that CO2 is compensatory to the body. All right, so what about NCLEX? Nope, not going to be tested on. It's good to know in practice, nuts to know all the medications and memorization of it, but the thing is NCLEX will stay away from this. If they're going to test on, it's going to be an ABG. So let's move on. We'll go into the what do we do to fix it? I mean, treat the underlying cause. I mean, I'll expect it to happen. Like I said before, it's the boat coming. So if you see this happening, look at why is this, hey, I see a boat over here. What's going on? And what's going on with my patient? I mean, I would never generally ignore over 30, so generally 22 to 26, low, I mean, 18s, I would start to look at it a little bit more, but little variations of 21, 27, 28. I mean, maybe something's going on, but the thing is that it could be the way you're working. Your lab values might be different, when it turns red or whatever it is. So generally, if I start to see it over 30, though, there's something else going on. And so the big thing about this, though, that I just want to point out is the concept. And the concept is that if one is high, the other one will be low. And if the other one is high, then the other one will be low. Now, how this works is if I circle one of these, that patient is acute in telling me that there's a boat coming, right? Because I circle it when it's abnormal. Now, if I circle both of them, that patient's more acute. And that's the basic principle. That means that you missed the original boat, and now they're really, really having difficulty compensating. Do they have emphysema? Are they have bronchitis? What's their underlying situation? Are they diabetic, DKA, and those type of things? All right, so let's break it all down into the concept. And then the concept is generally, we don't really look at this. We'll see it generally on the floor. Males or females, not really important, and ages are. Symptomology, if you know one, then you know the other. Generally, it says, I generally will say, look somewhere else. Look at somewhere else, metabolic, respiratory. Are they on oxygen? What's going on with them? Do I call the doctor about this? Generally not. Until it starts to have compensatory problems on the other side. Will they be on the monitor? Not necessarily. Blood pressure, hydration, labs continually monitor. Positioning, don't care. IV fluids, depending on what's going on. Medications tend to be primary cause to bump these up and down. If you think about it, acids, bases, all that stuff, antibiotics, all those things are acidic, and they have problems with these acid-base balances, so they tend to overcompensate. So if you're giving one, then you have a less production of CO2 and chloride and stuff like that. So that's always a good thing about it. It's like, it's kind of cool to look at, nuts to know, but not need to know. Vitals will be non-related to it. I mean, you'll see a lot of times with lower metabolic acidosis and higher metabolic alkalosis. Now, that just basically goes back to respirations, right? So higher the respirations, the more they start to blow off CO2 and become become alkalotic. Now, the lower the respirations, the more acidotic they become. And so you start to see these balances between the two. Primarily, we just talked about, not necessarily, none of this, no. Brain tends to be the problem. Mentation, sometimes with lethargy versus irritability. Back to acid-base balances. Breathing, heart, not necessarily, but breathing. Too small, you tend to see vitopenia, tachypnea. They tend to be metabolic patients or pulmonary patients. They can be discharged. I remember this is a lab that is just monitored for the time frame of what's going on with the patient. See the boat coming before it actually gets here. Because anybody, like I said before, with heart rate, anybody can see that 120 is a high heart rate, right? It takes that nurse to say 93, why? Right? That's the boat coming. And that's what we tend to look at. Well, that's about it. That wraps it up. This is Nursing Camp, and this is my Fishbone course, and this is covering all the labs within the Fishbone. And you can follow me on nursingkamp.com, Pinterest, and Facebook, and Instagram. And if you're not a member, become a member. Or click the subscribe button as you go through this course with me. The next one we're going to talk about is a real important one called BUN and creatinine in the kidney labs. Everything you need to know about them, and one of the most priority and highly testable things on the NCLEX. So let's move on.